Hey everyone, and welcome to This Explainer. Today, we're going to break down the complex medical fundamentals of one of the world's oldest and most notorious infectious diseases, tuberculosis. It's a chronic, communicable granulomatous disease that has quite literally plagued humanity for centuries. So, we're going to look at exactly how this microscopic invader operates, how our immune system scrambles to fight it, and the precise tools modern medicine uses to both diagnose and cure it.
Here's our roadmap for today. We're going to meet the microbe, map out its pathogenesis, compare primary versus secondary infections, spot the symptoms, diagnose the disease, and finally, look at the first-line treatment. Let's get right into it.
Section 1. Meet the microbe. Mycobacterium tuberculosis.
Discovered way back in 1882 by Robert Koch, this slow-growing, oxygen-loving bug has a very specific, famous trait. If you've ever studied TB, you've definitely heard the term acid fast. But why? What makes this specific bug so incredibly stubborn under a microscope, and why do our standard staining methods completely fail to show it?
Well, it's all about its armor. This bacterium literally wears a thick, waxy coat made of a lipid called mycolic acid. When you stain it with a red dye, like carbofuction, that waxy coat holds onto the dye so incredibly tight that even strong acid alcohol can't wash it away. It holds fast against the acid. Because of this, you're left looking at these bright red rods totally popping against a blue background.
Moving right along to Section 2, pathogenesis. Let's look at the invasion and the formation of granulomas.
So how does this airborne invader actually stage an attack after someone coughs or sneezes? It goes down in 3 distinct steps. Step 1, you inhale those suspended droplets. Step 2, they bypass your upper airway defenses and deposit right deep into the tiny air sacs of your lungs, the alveoli. Step 3, your alveolar macrophages, your lungs' frontline patrol cars, arrive and ingest the bacilli to destroy them. But here's the crazy part. The TB bacteria pull off an incredible trick. They survive directly inside the very macrophages meant to kill them, literally turning our own defensive cells into safe houses.
Now, your body doesn't just give up. It fights back by building a cellular prison around the infection called a granuloma. Inside this structure, you'll find epithelioid cells, which are just activated macrophages, and these massive Langhans giant cells, which have a really distinct horseshoe pattern of nuclei. And right in the center, because of the intense immune battle and a sheer lack of oxygen, the tissue basically dies off, creating a soft, white, cheese-like material known as caseous necrosis. This cheesy center is the absolute hallmark of a TB infection.
And you know, this initial microscopic skirmish leaves a permanent physical footprint behind. When you combine that primary lung lesion, which we call the GON focus, with the swollen, draining lymph nodes nearby, you get the GON complex. It's the classic anatomical signature that primary TB was there.
Section 3. Primary versus secondary TB.
How the disease behaves from here completely depends on whether this is a brand new exposure or old enemies waking up. Primary TB is usually that first exposure, often seen in children. It tends to form lesions in the lower lobes and is generally a much milder disease. Secondary, or reactivation TB, usually happens in adults when their immunity drops. The bugs wake up, but this time they head straight for the apex, the very top of the upper lung lobe. Why? Because TB absolutely needs oxygen to thrive, and the high oxygen tension at the lung's apex is like jet fuel for them, leading to rapid growth, severe tissue destruction, and highly infectious cavities.
Section 4. Spotting the symptoms.
So what does all this microscopic warfare actually look like in a patient? Constitutionally, you're looking at severe fatigue, major weight loss, and those classic drenching night sweats, usually accompanied by a fever that specifically spikes in the evening. On the respiratory side, a chronic, productive cough lasting more than 2 weeks is your biggest red flag. And of course, sometimes this escalates to hemoptysis, coughing up blood, which happens as that lung tissue is actively getting destroyed.
Next up, Section 5. Diagnosing the disease.
Confirming the bug is there requires some targeted investigations, and we often start screening with the classic Mantoux skin test. We inject a purified protein derivative just under the skin, wait 48 to 72 hours, and then look for an induration, a hard raised bump. If it's 10 millimeters or larger, it's positive. But remember this absolutely crucial distinction. A positive Mantoux only means the immune system has been exposed to TB at some point. It does not necessarily mean the patient has an active, currently spreading infection.
To prove there's an active pulmonary infection, we really need to look at the patient's sputum. The classic ZN stain lets us physically see those bright red acid-fast rods right under the microscope. But honestly, modern molecular testing, like the CBNAT or GeneXpert, has been an absolute game changer for TB care.
It's incredibly fast and immediately tells us if the strain is resistant to our major drug rifampicin. Finally, growing the bacteria on a Lowenstein-Jensen culture is still the gold standard for absolute confirmation. But because TB is such a slow grower, you might be waiting a frustrating 4 to 8 weeks for a final result.
Which brings us to Section 6, the first-line treatment.
Once we have a solid diagnosis, we launch a highly structured, multi-drug counterattack. The standard cure isn't a quick fix. It's a strict 6-month journey. Month 0 kicks off a heavy-hitting 2-month intensive phase using 4 different drugs to rapidly kill off the multiplying bacilli and halt transmission. After those 2 months, once the bacterial load has massively dropped, we step down into a 4-month continuation phase. We use slightly fewer drugs here just to mop up any of those lingering, slow-growing persisters.
Now, because these bacteria are so tough, this HRZE drug regimen is intense, and you absolutely have to know the highly specific side effects for each drug. Isoniazid, or H, inhibits mycolic acid, but can cause peripheral neuropathy, which is exactly why we always supplement it with vitamin B6. Rifampicin, R, inhibits RNA polymerase, but will harmlessly turn the patient's urine an intense orange-red. Pyrazinamide, Z, is great for penetrating those acidic granulomas, but it can spike uric acid levels, leading to joint pain. And finally, ethambutol, E, stops cell wall construction but carries a very real risk of optic neuritis, so you have to keep a close eye on the patient's vision.
This HRZE regimen has saved literally millions of lives. But here's where things get a bit scary. It has to be taken strictly. When treatments are incomplete, we see the rise of multi-drug resistant TB, or MDR-TB, where the bugs just stop responding entirely to our 2 best weapons, isoniazid and rifampicin. So as we wrap up this explainer, looking at the heavy toll this ancient disease still takes today, I have to leave you with this vital question. With the terrifying rise of these drug-resistant strains, if our standard first-line shield completely shatters, are we globally prepared for what comes next?